This talk will be about mutations associated with resistance to non-nucleoside RT inhibitors, or NNRTIs. These are my disclosures. NNRTIs are characterized by having diverse chemical structures which have been optimized to bind to a pocket in the RT enzyme that is close to but distinct from the enzyme's active site. The NNRTI binding pocket is highly adaptable, and therefore the NNRTIs can differ dramatically in their structure. The figure on the right shows an X-ray crystal structure of the HIV-1 reverse transcriptase bound to an NNRTI shown in yellow. The NNRTI binding pocket lies beneath the enzyme's active site. When bound to the RT enzyme, the NNRTI restricts the movement of the enzyme's thumb and fingers. Drug resistance mutations shown in red exclude the NNRTI from its binding pocket. We have collected a large amount of sequence data from patients developing virological failure while receiving the first-generation NNRTIs, nevirapine, and efavirenz. However, much less data are available for the second-generation NNRTIs, in particular Doravirine. The few sequence data available for Etravirine are in patients who had a history of virological failure on a first-generation NNRTI. Nonetheless, sufficient data are available to show that the NNRTIs select for different drug resistance mutations in patients. K103N and V106M are the most common efavirenz-selected drug resistance mutations. V106M occurs commonly in subtype C isolates. L100I and P225H often occur in combination with K103N. Y181C, Y188L, and G190A and S are other commonly selected drug resistance mutations. E138K, K101E, Y181C, and H221Y are the most common rilpivirine-selected drug resistance mutations. Additional mutations that have occurred in patients and during in vitro passage experiments include L100I and F227C. Mutations at positions 106, 227, and 318 are the most common Doravirine-selected mutations. Y318F is associated with a greater than 10-fold reduced Doravirine susceptibility. Therefore, it is important to know whether this position was sequenced, because not all genotypic assays sequence beyond RT position 300. Extensive phenotypic data are available for efavirenz, but much less data are available for rilpivirine and Doravirine. The figure on the right shows the results of a regression analysis for efavirenz, in which each drug resistance mutation is an explanatory variable and the fold reduction in susceptibility is the outcome variable. The height of the bars are proportional to the mutation's impact on susceptibility. The most common single mutations with the greatest effect on efavirenz susceptibility include K103N, V106M, Y188L, and G190A and S. Other less common efavirenz-selected mutations that also confer a large reduction in susceptibility include L100I, K101P, G190E, and M230L. The most common drug resistance mutations with the greatest effect on rilpivirine susceptibility are L100I, Y181C, I, and V, Y188L, and M230L. Although K103E and E138K are the most common rilpivirine-selected drug resistance mutations in patients, they have a minimal effect on rilpivirine susceptibility. This suggests that low levels of resistance are sufficient to cause virological failure on a rilpivirine-containing regimen. The drug resistance mutations with the greatest effect on Doravirine susceptibility and which have occurred in patients are V106A, Y188L, F227C and L, M230L, and two drug resistance mutations that are not shown in the figure, L234I and Y318F. There are several accessory drug resistance mutations that are also associated with reduced susceptibility only when they occur in combination with other NNRTI-associated drug resistance mutations. In the next two slides, I will dive somewhat deeper into rilpivirine and doravirine resistance because they have become the most commonly used NNRTIs. This figure shows those patterns of drug resistance mutations that were present in at least two isolates undergoing rilpivirine susceptibility testing. The x-axis shows the fold reduction in susceptibility on a log2 scale. A line is drawn at 2.5-fold because wild-type isolates nearly always have a fold reduction in rilpivirine susceptibility that is less than 2 to 2.5-fold. This upper limit of the fold reduction in susceptibility to wild-type isolates is referred to as the technical or biological cutoff for a drug. As noted previously, among the drug resistance mutations associated with the highest reductions in susceptibility, K101P, Y181IV, and G190E are uncommon, while Y188L and certain combinations of mutations are common. Interestingly, the most commonly occurring drug resistance mutations in patients receiving rilpivirine, E138K and K101E, alone or even together, are generally not associated with marked reductions in susceptibility. There is variability in the fold reduction in susceptibility for each pattern because some rare NNRTI drug resistance mutations were not considered when defining the drug resistance mutations to include in the pattern shown here, and because some variations not considered to be drug resistance mutations can have some effect on NNRTI susceptibility. Finally, several NRTI resistance drug resistance mutations can reduce the effect of NNRTI resistance drug resistance mutations when they are associated with reduced replication fitness. Rilpivirine is unique among NNRTIs because it selects for mutations at position 138, which can cause low-level reductions in rilpivirine susceptibility. E138A is a polymorphic mutation that occurs in 2% to 5% of untreated persons, depending on viral subtype. Its clinical significance for rilpivirine is not known. It is listed as a rilpivirine-associated drug resistance mutation in the FDA package insert, and patients with E138A were excluded from the rilpivirine clinical trials. There have been about 200 published Doravirine susceptibility results performed using the Monogram Biosciences PhenoSense assay or the Merck Research Lab assay, which seems to be concordant with the PhenoSense assay. This figure shows those patterns of drug resistance mutations that were present in at least one isolate undergoing susceptibility testing. The x-axis shows the fold reduction in susceptibility on a log2 scale. Lines are drawn at the 3-fold mark, which is the technical or biological cutoff for Doravirine in the PhenoSense assay, and at the 10-fold mark, primarily because this is a convenient benchmark. 6 drug resistance mutations have consistently been associated with greater than 10-fold reduced susceptibility to Doravirine, including V106A, Y181, Y188L, M230L, and Y318F. F227C and L have been associated with greater than 100-fold reduced susceptibility when they occur in combination with other mutations, particularly V106I, A, and M. Certain drug resistance mutations require further study, such as L234I, which has been selected in vitro and which in combination with V106A has been associated with greater than 100-fold reduced susceptibility. Certain combinations of two non-canonical Doravirine-associated mutations, such as K103N in combination with L100I or P225H, are associated with 3 to 10-fold reduced susceptibility, and at least 2-3 mutation combinations lacking canonical Doravirine-associated mutations have been associated with greater than 10-fold reduced susceptibility. The fact that most patients who develop virological failure while receiving Doravirine have high levels of resistance may suggest that Doravirine retains activity against viruses with lower levels of reduced susceptibility, such as those in the 3 to 10-fold range. A systematic review of the impact of pretreatment NNRTI drug resistance mutations on the risk of virological failure on a first-line NNRTI-containing regimen was recently published. One part of this review analyzed the effect of baseline NNRTI resistance mutations on a first-line regimen containing tenofovir plus 3TC or FTC plus efavirenz. A meta-analysis of 4 clinical trials and 2 cohort studies showed that pretreatment drug resistance was associated with an increased risk of virological failure. The risk of virological failure was particularly high for patients who had prior ART experience, such as those reinitiating ART after an interruption in therapy, as compared to those who had been ART naive. This was in part because those reinitiating therapy were more likely to have had NRTI as well as NNRTI associated mutations, and because pretreatment drug resistance in patients with ART experience may be a marker for non-adherence. We published a study 15 years ago providing another likely explanation for why NNRTI-associated drug resistance mutations are likely to be associated with a higher risk of virological failure in patients who are NNRTI experienced compared with those who are ART naive and have transmitted drug resistance. We performed direct PCR Sanger sequencing and deep sequencing in 13 ART naive patients and 20 NNRTI experienced patients who had K103N. Among the 13 ART naive patients with K103N detected by PCR sequencing, none had additional mutations detectable by deep sequencing that would cause resistance to the second generation NNRTIs Etravirine or Rilpivirine. By contrast, among 20 ART experienced patients with K103N, sequences from the 7 patients shown in the table on this slide had additional NNRTI DRMs that were detected only by deep sequencing. These additional drug resistance mutations and their numbers are shown in the last 3 columns of the table. Those that would reduce susceptibility to Etravirine and Rilpivirine are shown in bold and or underlined. Their proportions in the sample are indicated in parentheses. On average, nearly 3 additional NNRTI-associated mutations were present by deep sequencing at proportions above 1%, but below the approximately 20% threshold of Sanger sequencing. A second-generation NNRTI may be active against viruses from persons with NNRTI-associated transmitted drug resistance, provided no drug resistance mutations associated with that inhibitor are present. Indeed, in a small study, which was terminated as a result of limited enrollment, showed that tenofovir plus 3TC plus Doravirine was highly effective in 8 study participants with transmitted drug resistance associated with K103N, Y181C, or G190A. However, as the study on this slide and other similar studies have shown, acquired NNRTI resistance is often associated with additional drug resistance mutations that may not be detectable by standard sequencing. There was only one clinical trial in which NNRTI experienced participants were randomized to a different NNRTI. The DUET trial recruited participants between 2005 and 2006. It compared treatment with the second-generation NNRTI Etravirine with placebo in participants with virological failure who had at least one NNRTI-associated drug resistance mutation and at least 3 protease inhibitor-associated drug resistance mutations. All participants also received boosted darunavir and 2 other investigator-selected antiretrovirals. The study found that participants receiving Etravirine were significantly more likely to attain a virus load less than 50 copies per mil at week 48, 61% versus 40%. A follow-up study examined the genotypic and phenotypic predictors of response to Etravirine in this trial. A scatter plot shown in this figure examined the fold reduction in Etravirine susceptibility at baseline versus the change in virus load from baseline to week 24. 2 models were used to determine how phenotypic resistance predicted the virological response to Etravirine salvage therapy. These models had to control for the baseline level of darunavir resistance and for the predicted activity of the 2 other investigator-selected antiretrovirals. The figure shows that there was an inverse relationship between the fold reduction in Etravirine susceptibility and the reduction in virus load. When the fold reduction in susceptibility was above 3-fold, there was a reduction in response to Etravirine compared with those viruses that had less than 3-fold reduced susceptibility. And when the fold reduction in susceptibility was above 10 to 13-fold, there was no longer any virological response that could be attributed to Etravirine. Although Etravirine is now used infrequently, this study demonstrates the complexity of correlating resistance to a drug with response to that drug in salvage therapy regimens containing multiple drugs. Nonetheless, based on this study, the PhenoSense assay provides some guidance on how to interpret Etravirine susceptibilities. Of note, for the remaining NNRTIs, the only cutoff provided is the upper limit for the fold reduction in susceptibility of wild-type isolates, a cutoff referred to as the technical or biological cutoff. In conclusion, efavirenz, rilpivirine, and doravirine very often select for different drug resistance mutations. In addition, NNRTI-associated drug resistance mutations often differ in their effects on these 3 NNRTIs. Virological failure on a rilpivirine-containing regimen is often associated with drug resistance mutations that cause low-level rilpivirine resistance, consistent with its low genetic barrier to resistance. In contrast, virological failure on efavirenz and especially on doravirine-containing regimens are usually associated with drug resistance mutations with high levels of reduced susceptibility. Although a small set of canonical drug resistance mutations can cause high levels of Doravirine resistance, several combinations of 2 non-canonical drug resistance mutations can reduce Doravirine susceptibility by 3 to 10-fold, but while 3 or more non-canonical Doravirine resistance mutations can reduce Doravirine susceptibility greater than tenfold. Rilpivirine and Doravirine may be successful in treating ART-naive patients with drug resistance mutations that do not reduce their susceptibility, but the use of these NNRTIs in persons with acquired NNRTI-associated drug resistance mutations is likely to be risky. The data that I reviewed in this presentation are summarized to a large extent in the notes section of the HIV genotypic resistance test interpretation program and in a very brief format in a PDF handout. The HIVDB website also contains a list of all mutation penalty scores. There are individual mutation penalty scores for nearly all drug resistance mutations and several penalties that go into effect only when certain drug resistance mutation combinations are present. The total mutation penalty score for a drug is based on adding all of the individual and combination penalty scores. An in-depth description of the HIVDB resistance interpretation program is described in another presentation. All drug resistance mutations that receive a penalty score and some that don't are accompanied by a comment. The complete list of comments for each drug class can also be viewed on the website. There is also a table that lists pre-computed scores for all combinations of drug resistance mutations present in the database. The table can be sorted by the number of sequences so that the most common drug resistance mutation patterns are shown at the top, or by those drug resistance mutations associated with the highest scores for an NNRTI. It is very useful for us to check this table to make sure that updates to the mutation penalty scores lead to the results intended for actual virus isolates. This figure shows the top of the table sorted by the number of sequences in which the most common drug resistance mutations are shown, ranging in number from about 1,700 to 13,000. And a section of the table somewhat lower down showing those patterns occurring in 147 to 170 sequences. Thank you for your attention. If you have any questions or suggestions, don't hesitate to email us.